So today I am discussing a very important complaint, a very important lecture that is about lethal fetal anomalies and its management. So this topic mostly comes in OSCEs and sometimes in bcqs as well, but mostly this is a topic of OSCEs. So what are the lethal fetal anomalies, how they should be managed, what important points are included in the counseling of the parents. We will discuss all these points in this lecture. Congenital anomalies accounts for 20% of infant deaths. So the congenital anomalies that causes fetal deaths, they account for 20% of infant death. This picture is for the reference of certain different congenital anomalies from which fetus or an infant could suffer fetal demise occurs. What are the lethal fetal anomalies? So here I have concised few of the very important and common lethal fetal anomalies that results in the death, intrauterine death of the fetuses or early neonatal death. These includes brain anomalies, most common of which is anencephaly, certain skeletal anomalies, skeletal dysplasia, genetic disorders, most commonly it includes triploidy and trisomies 13, 15 and 18. Bilateral renal tract anomalies, it includes renal agenesis, multicystic or dysplastic kidneys, and polycystic kidney disease. So these are the most important lethal fetal anomalies which results in IUD fetuses as well as early neonatal deaths. Okay, so what responsibilities are assigned to whom? This should be known by our students. So while answering during OSCE stations, you should know what role has to be assigned to each of the person who is attending this kind of patient. So role of sonographer is he or she should impart information about abnormal findings to women and should follow the appropriate referral pathway. So whenever any kind of lethal fetal anomaly or kind of soft markers are they are diagnosed on ultrasound scan or they are shown on scans, so the patient has obviously have to be referred to the multidisciplinary care as well as the fetal management unit. So appropriate referral should be done and the woman should be provided the necessary information regarding the anomaly which is diagnosed in the ultrasound scan. The role of midwives is to provide information and outcome of screening tests. So here in Pakistan, this role is fulfilled by our consultants and doctors. But if you talk about UK and the practice which is in our neighboring countries, there this role is assigned to the midwives. Ensure the support to women and her family in case a fetal anomaly is diagnosed. So this role is also of a midwife. Okay, so what role obstetrician has to perform? He or she should do non-directive, non-judgmental supportive approach. So logically, you should not provide the last judgment to the patient or to both the partners that this is a lethal fetal anomaly and it should be terminated anyhow. But you can provide all the necessary information and leave the judgment onto the couple or whoever attendants are there present with the woman. Women and their families are supported to decide within constraints of law whether or not to have pregnancy terminated. So this decision it has to be left upon the families and the partners. Effective communication between professionals at primary, secondary and tertiary levels. Arrange a well-organized follow-up. So this is very important. Whenever this kind of anomaly is diagnosed and suppose the couple or the family, they have decided to just carry on with the pregnancy. So a well-organized follow-up has to be arranged, timely follow-up to recognize or to diagnose any other anomalies associated with the current or present anomaly, and it has to be also counseled to the family and the parents. Diagnosis and breaking news. Provide information leaflet, screening test for you and your baby. So this is very important. Whenever certain anomaly is diagnosed, then there should be some prepared leaflets of all the different diseases that now this has been diagnosed, what other screening tests are necessary for the mother and the baby, to diagnose the or to assess the severity of the disease. Provide purpose and potential outcome of a screening test. What purpose of the proposed screening test is, and what kind of final information it can provide. What are the complications of a particular screening test. So all of these things have to be very clear in the mind of the attendees, and it has to be communicated effectively. Suspected and confirmed fetal anomalies refer if there are any kind of suspected anomaly or the anomaly has been confirmed. There should be referred to fetal medicine and consulted in 3 days or fetal medicine unit in 5 days. So this is the protocol that is that is the NHS protocol, which is followed here. So this kind of protocols can be maintained in the hospitals here in Pakistan as well. Give information in non-medical and simple language with both visual and written information. Talk in a private space with etiquette. Options regarding termination of pregnancy or continuing should be discussed using a non-biased approach. Okay, so regarding the antenatal management, termination of pregnancy. Parents agreed for termination of pregnancy. Gestational age is 21 weeks plus 6 days. Then refer to fetal medicine tertiary unit for feticide should be done. What is feticide? This is the injection or the installation of intracardiac KCl, potassium chloride injection, to cause fetal death, and then the pregnancy can be terminated. So this is for the pregnancy of 21 weeks and 6 days. If parents refuse feticide, management should be discussed with all concerned healthcare professionals before termination of pregnancy regarding neonate of the continuation of pregnancy. Make a well-documented plan of care for pregnancy. Suppose if the parents and attendees have agreed for continuation of the pregnancy, then a well-documented plan has to be handed over to them based on diagnosis and prognosis of the particular disease. Support the decision of the family. Provide continuous care by multidisciplinary treatment. Frequent antenatal follow-ups for confirmation of fetal viability. Diagnose complications in a timely manner. So all these are very important points which are to be followed while dealing with such patients. Counsel regarding increased risk of complications in certain anomalies. So there are certain anomalies which results in risk to the mother as well, which they need very important counseling, because there is the risk to the health of the mother as well in these anomalies. These include polyhydramnios, lethal skeletal dysplasia, trisomy 13, and triploidy. These anomalies mostly cause maternal preeclampsia associated with fetal hydrops. So it is very important to let the parents know or the family know about the possibility of this complication in the mother as well. What is Ballantyne syndrome, maternal hydrop syndrome, mirror syndrome? What occurs that if there is fetal hydrops, then the same kind of picture is present in the mother as well. So it is the mirroring of fetal hydropic state associated with hypertension, severe edema, and maternal eclampsia. This is known as Ballantyne syndrome. Important points to discuss with consultant pediatrician and obstetrician. What are the important points? It includes care of the neonate, which includes analgesia requirement for the neonate as well as the NICU facilities if they are provided in a particular hospital or not. While delivering such a fetus who has multiple kind of anomalies, so NICU mostly is needed in these fetuses. Preferred mode of delivery for anomalous baby and intrauterine fetal death. So the preferred mode of delivery is vaginal delivery with minimal intervention. However, cesarean sections are recommended in case of any other complications or previous cesarean section. Otherwise, the preferred mode is vaginal delivery. Postpartum care and information regarding postmortem examination should be discussed. Both parents should be involved in the meeting. So the important point is regarding the postmortem examination, whether the parents are agreed for the postmortem or not, and what tissues could be sent for this procedure. Care in labor and delivery. Senior midwife should be present. All form of analgesia should be available. It includes Antonox, diamorphine, and epidural analgesia. Counsel regarding need for induction of labor. Cesarean section in special circumstances. So cesarean section is indicated only in case of special circumstances. Continuous fetal monitoring is not advocated during labor because the chances of fetal viability are already very low. Intermittent fetal heart auscultation can be done. Preferred mode of delivery should be vaginal. So what about the neonatal care? Fetuses with abnormalities incompatible with life. Avoid inappropriate attempts at resuscitation. So this is very important. When the anomaly is already known and when it is also it has been assessed that this fetus would not be compatible with life. So inappropriate attempts at resuscitation should be avoided. Severe anomalies that are not immediately fatal provide compassionate care in neonatal unit, local hospital, or at home in liaison with the neonatal team. So this is for those anomalies that are severe but they are not immediately fatal. Postmortem examination should be encouraged if diagnosis of fetal anomalies was suspected but not confirmed. If parents decline complete postmortem, ensure partial postmortem, which includes placental skin biopsy for cytogenetic analysis and DNA storage. X-rays, CT scan, MRI, and geneticist review should be considered. So this is included in the partial postmortem examination. Regarding registration with births and deaths, before 24 weeks of gestation, if there is no breathing, no signs of life, no need to register the birth. Issue a certificate confirming that baby was born before age of viability. Now, if it occurs after 24 weeks of gestation and there is no breathing or signs of life, register the birth within 3 months, classifying it as stillborn. After 24 weeks of gestation, shows signs of life but subsequently dies, both birth and death need to be registered. So this is very important. These are the set protocols which are to be followed. In the postnatal care, it should be provided by same obstetrician who looked after the mother during pregnancy and delivery. Individualized management should be formulated for future pregnancies according to test results. Refer to obstetrician with special interest in fetal medicine and genetics. So much for your patient listening, and hopefully this lecture will be beneficial for our students and the consultants as well. Now, how the pregnancy has to be terminated, it will be discussed in the next lecture. Thank you.